All right, welcome everyone. Today, we're going to tackle something that's absolutely essential for every single psychiatry resident, mastering thyroid function tests. Let's jump right in.
So, let's just get right into it. You've probably heard the thyroid called psychiatry's great mimic, right? And honestly, it's for a really good reason. You could have a patient present with what looks for all the world like a classic psychiatric issue. I'm talking debilitating fatigue, anxiety that just won't quit, even full-blown psychosis. And the root cause might not be in the head at all, but right here, in the neck.
And here's what's so wild. The presentations can be polar opposites. You know, on one hand, you've got hyperthyroidism, which can look exactly like mania, a panic disorder, or even delirium. But then, on the flip side, hypothyroidism can perfectly mimic major depression or a cognitive disorder. It's this huge range that makes a systematic approach to testing not just a nice-to-have, but an absolute must.
Okay, so how do we make sense of all this? Well, before we can decode the lab tests, we need a really simple but super powerful mental model for how the thyroid's feedback loop actually works.
Okay, so here's the official breakdown, the HPT axis. You've got the hypothalamus kicking things off with TRH. That TRH signals the pituitary to release TSH. Now, TSH is the key player here. It's the direct messenger that tells the thyroid gland, hey, time to make your hormones. Then, those hormones, T4 and T3, go out into the body and also circle back to the brain to say, okay, we've got enough, you can cool it. It's a classic negative feedback loop. But you know what? There's a much, much easier way to think about all this. And here it is. This analogy is gold. Seriously. Just think of it like the heating system in your house. The TSH, that's your thermostat on the wall. It senses how cold or hot the room is. The thyroid gland itself, that's the furnace down in the basement, the thing that actually generates the heat. And the T4 hormone? Well, that's the heat itself, warming up the house. If you can remember this, thermostat, furnace, heat, you've basically cracked the code for interpreting these tests. All right, let's get practical. We're going to walk through the 5 key lab patterns you'll see over and over again in your practice, and we'll use our heating system analogy to figure out what's going on. Okay, rule number 1, and this is crucial. Always start with TSH. Always. It's your most sensitive first-line screening tool. Think about it. If the thermostat says the temperature in the house is perfectly normal, you probably don't need to go checking on the furnace, right? The system's likely in balance. If TSH is normal, you're usually good to go. All right, pattern number 1, primary hypothyroidism. So, your labs come back and TSH is high, but free T4 is low. What does our analogy tell us? Well, the thermostat is cranked all the way up. It's screaming for heat, but the furnace, it's broken. It's not producing any heat, so the house is cold. The problem here isn't the thermostat. The problem is the furnace itself, the thyroid gland.
Now for the opposite scenario, primary hyperthyroidism. This time, TSH is low and free T4 is high. Let's think about it. The furnace is stuck on full blast, just pumping out heat like crazy, making the house dangerously hot. The thermostat, being smart, has shut itself completely off. It's saying, stop, no more heat. But the furnace isn't listening, it's gone rogue.
Okay, now this next one is huge for us in psychiatry, subclinical hypothyroidism. You get a high TSH, but the free T4 is normal. What's happening? Well, the thermostat is turned way up, which tells you the system is working overtime. The furnace is struggling, but it's just barely managing to keep the house at a normal temperature. This state of compensation is something you'll see a lot in patients with more severe or treatment-resistant depression, so keep your eyes peeled for this one. And here's its counterpart, subclinical hyperthyroidism. TSH is low, but free T4 is still normal. In this case, the furnace is running a little hot. It's a bit overactive, so the thermostat has turned itself down to try and compensate. The house temperature is okay for now, but this tells you the system is out of whack, and you need to monitor this patient because it could easily progress to full-blown hyperthyroidism. Okay, last pattern. What if both TSH and free T4 are low? This can be confusing, but the problem here is probably not the thyroid itself. This is what we call non-thyroidal illness, or euthyroid sick syndrome, and you see it in really acutely ill patients. Think of it this way. The whole house, the patient's body, is dealing with a major crisis, like a severe infection. The brain's response is to just shut down all non-essential systems to conserve energy, so it tells the entire heating system, power down now.
So now we know what is wrong with the heating system. The next logical question is, why is it broken? That's where thyroid antibodies come in.
Let's stick with our house analogy because it just keeps working. Think of antibodies as the inspectors you call in. You know something is wrong with the furnace, so you call these specialists, and their one job is to figure out if an intruder, in this case the body's own immune system, is the one down there messing with the controls.
And really, there are two main inspectors you need to know. First, you've got the thyroid peroxidase antibody, or TPO antibody. This is your go-to inspector for Hashimoto's thyroiditis, which is far and away the most common cause of autoimmune hypothyroidism. Then you've got the TSH receptor antibody, or TRAP. This is the inspector for Graves' disease, the main cause of autoimmune hyperthyroidism. Simple as that.
And when you call that TPO inspector, the results are pretty darn clear. Get this. Over 90% of patients with Hashimoto's will have elevated TPO antibodies. That's a huge number. So if you see a positive TPO test, it's a very, very strong sign that you're dealing with Hashimoto's. Okay, and while we're talking about TPO antibodies, there's one rare but absolutely critical diagnosis you have to keep in the back of your mind: Hashimoto's encephalopathy. A patient might present with sudden confusion, altered consciousness, even seizures, and have these high TPO antibodies. The reason it's so critical to catch is that it's a steroid-responsive encephalopathy. Making this diagnosis can literally be life-changing for your patient.
All right, let's wrap up with a quick-fire round of clinical pearls. These are the high-yield tips you can take and apply in your clinic tomorrow. Pearl number 1, lithium. Before you write that first script for lithium, you must get a baseline TSH, and you need to keep checking it periodically. We all know lithium's effects on the thyroid are significant and well documented. It's on us to catch any problems early.
Pearl number 2, and this is a sneaky one. Ask about biotin. It's in everything these days. Supplements for hair, skin, and nails. The problem is, it can seriously interfere with our thyroid assays, giving you completely bogus results that will send you on a wild goose chase. So make it a habit. Tell your patients to stop taking it for at least 2 days before they get their blood drawn.
Pearl number 3 is for your patients with treatment-resistant depression. If you're stuck, don't forget to look at the thyroid. We talked about subclinical hypothyroidism, and there's good evidence that augmenting their antidepressant with a little thyroid hormone, specifically aiming for a TSH of less than 2.0, can be a real game changer.
And our final pearl. Think about your geriatric patients. Hyperthyroidism doesn't always look like the textbook. Instead of anxiety and restlessness, you might see something called apathetic hyperthyroidism. It can look like lethargy, social withdrawal, or even a new dementia. So don't get fooled by the atypical presentation in older adults.
So, there you have it. The thermostat, the furnace, the inspectors. It's a simple framework, but it's powerful. The next time you have a patient with treatment-resistant depression or some unexplained cognitive changes, I hope this makes you stop and ask that crucial question. Is it the brain or is it the thyroid? Being able to answer that will make you a better psychiatrist.